welcome to the deep dive. Today, we're embarking on a really fascinating exploration. We're going to look at the intricate ways medications actually move through your body.
That's right. Think of it as, understanding the incredible journey a drug takes inside us, from the moment it gets in right until it's finally gone.
And to guide us on this journey, we've got our source material here, a chapter from a pharmacology text. This is our map for this deep dive into pharmacokinetics, specifically absorption, distribution, metabolism, and elimination.
Or ADME, as it's often called.
Yeah, ADME, right.
And our mission today, it's really to go beyond just, defining those terms. We want to pull out the core principles, the how and why behind it all.
So you can understand why doctors give drugs certain ways, like a pill versus a shot.
Exactly. Understanding that gives you real insight into how these choices impact the drug's path and ultimately its effects on you.
Okay, let's dive in then, starting with the very first hurdle a drug faces, getting across the body's barriers. Our source really flags the plasma membrane as the main gatekeeper here.
Yeah, and it's crucial to see it's not just a static wall, it's dynamic, very selective. It's this lipid bilayer, but it's packed with proteins, receptors, channels, transporters.
They're deciding what gets through.
Pretty much. They control the traffic.
And one key way drugs get across is just passive diffusion.
Yeah.
Sort of flowing downhill concentration-wise.
That's a big one, yes. It depends heavily on how well the drug dissolves in lipids, how oily it is. Makes sense for slipping through that lipid membrane.
But it's not just oiliness, right? The source talked about charge, ionization.
Right, that's super important too. Basically, whether a drug carries an electrical charge affects how easily it crosses. Weak acids tend to lose their charge in acidic places, making them more lipid-soluble there. Weak bases, they do the opposite. They lose their charge in more alkaline, basic environments.
And this actually matters in practice. The source mentions ion trapping.
Oh, absolutely. It's not just theory. Because pH varies in different body parts, a drug can get sort of trapped on one side of a membrane where it's more ionized and can't cross back easily.
Like holding it in one place.
Exactly. And we can even use this, like making the urine more alkaline helps flush out aspirin, which is a weak acid, during an overdose. We trap it in the urine so it can't get back into the body.
Clever.
It is. And the antihistamine example is perfect. Newer ones, like loratadine, they're designed to be more ionized at body pH.
So they struggle to cross into the brain, the blood-brain barrier.
Precisely. That's why they cause much less drowsiness than older ones, like diphenhydramine, which cross much more easily. It's smart drug design based on this principle.
Okay, so not just slipping through. There's also carrier-mediated transport, like protein helpers.
Exactly. Specific doors for specific molecules. You've got facilitated diffusion. That's where a protein helps a drug move down its gradient. No energy needed.
Like the OCT1 transporter mentioned for thiamine and metformin?
Yeah, that's a good example. Helps them get across.
And then there's active transport. That sounds like more work.
It is. It needs cellular energy, ATP usually, because it can pump drugs against their concentration gradient from low to high concentration. Wow.
Okay.
These are very specific, selective, and they can get maxed out, saturated if the drug concentration gets too high. Think of the Na plus K plus pump or those ABC transporters.
The source highlights one called P-glycoprotein or MDR1.
Oh, yes, PGP. That one's fascinating. It's basically an efflux pump. It actively throws things out of cells.
Out. So it can limit absorption.
It can. In the gut lining, it pumps drugs back into the intestine, reducing how much gets absorbed. In the brain, its protective kicks stuff out trying to cross the blood-brain barrier.
That sounds like it could be bad for, say, cancer drugs.
Unfortunately, yes. It's a major mechanism of drug resistance in cancer. The cancer cells use PGP to pump out the chemotherapy drugs. So yeah, PGP really shapes how we approach treating lots of things. Sometimes we need ways to get around it.
And there are other transporters, too. The SLC superfamily.
Right, another big group. They often use ion gradients, not ATP directly, for energy, like the Na plus NADH 2 plus exchanger, or neurotransmitter transporters, D8-NET, SERT, big targets for drugs treating depression and other conditions.
So many ways across. What about just squeezing between cells? Paracellular transport.
That exists, but it's pretty limited for most drugs, especially where cells are tightly packed together, like in the brain. Those tight junctions really block that route.
Right. Okay, so the drug is past the first hurdle.
Yeah.
Now, absorption, getting it from, say, your mouth into the bloodstream.
Exactly. Absorption is that movement from the administration site, mouth, skin, muscle, wherever, into the central circulation, the blood. If it's a solid pill, Step 1 is it has to dissolve.
And then bioavailability comes in.
Yes.
F value.
Yes, F for fraction. It's the fraction, the percentage of the dose you took that actually makes it into your systemic circulation unchanged, ready to work.
So IV is 100%. F equals 1.
Correct. Straight into the vein, bypasses all the absorption barriers.
But for pills, it's trickier. The source mentions dissolution, drug properties.
Gut metabolism, liver metabolism, that's the big one, the first pass effect.
Ah, the liver getting first dibs.
Pretty much. Before the drug even reaches the rest of the body, it goes through the liver via the portal vein. And the liver can metabolize or break down a significant chunk of it.
So less active drug actually gets out to the body.
Exactly. Which means for some drugs, the oral dose has to be much higher than an IV dose to get the same effect. It also mentioned again that less charged, more lipid-friendly drugs generally get absorbed better from the gut, and the huge surface area of the intestine is key for absorption too.
Finding that sweet spot for solubility.
Right. Oily enough to cross, but not so oily it just gets stuck in membranes or fat.
And obviously how you take the drug matters hugely. Oral is commonest, easy, safe, cheap.
But it has downsides. Some drugs just aren't absorbed well, or they cause nausea or get destroyed by stomach acid or enzymes. Plus, interactions with food, other meds, and just, needing the patient to actually take it correctly.
Yeah, compliance.
To deal with some of that, we have things like enteric coatings.
To protect the drug in the stomach.
Or protect the stomach. Both, potentially. Lets it dissolve later in the intestine. And controlled release forms. They're designed to let the drug out slowly over hours.
Good for drugs that wear off quickly. Short half-lives.
Exactly. Reduces how often you need to take it, gives smoother levels, especially overnight, avoids those big peaks and troughs in concentration.
What about under the tongue? Sublingual. Nitroglycerin you mentioned.
Yes. That route bypasses the gut and liver metabolism initially. The veins under the tongue drain directly into the general circulation, so it's fast, and avoids that first pass hit.
Then there's parenteral injections. Generally faster, more predictable.
Generally, yes. Bioavailability is often close to 100% or predictable. Good for emergencies or if someone can't swallow, but you need sterile technique, it can hurt, and self-injection isn't always easy.
And there are different types. 4V is instant, complete.
Right. Subcutaneous under the skin is slower, more sustained. Absorption can be tweaked by, say, particle size or adding things to constrict blood vessels locally. Think insulin or hormone implants for slow release.
And intramuscular, in the muscle.
Absorption is usually pretty quick. Depends a lot on blood flow where you inject. Arm muscle, deltoid or thigh, vastus lateralis, are faster than the gluteal muscle. Heat or exercise can speed it up. Depot injections use this route for very slow release over weeks or months.
And those specialized ones, intraarterial, intrathecal.
Intraarterial is rare, aims for high concentration in one specific organ, like a liver tumor. Intrathecal goes directly into the cerebrospinal fluid, bypassing the blood-brain barrier. For spinal anesthesia or treating CNS infections.
The lungs, too. Inhaling drugs.
Huge surface area, very rapid absorption, avoids first pass. Great for anesthetic gases or delivering drugs right to the lungs for asthma, for instance, like inhaled nitric oxide.
And topical. Creams, patches.
Mostly for local effect, but some systemic absorption can happen, especially through damaged skin. Oily bases help. Transdermal patches are designed for controlled systemic delivery, nicotine, hormones, pain meds like fentanyl.
Rectal. Seems less common.
It is. About half the dose bypasses the liver, so less first pass effect, but absorption can be erratic. And yeah, the source mentions newer things like drug-releasing stents, nanoparticles, lots of innovation in delivery.
And bioequivalence, making sure generics work the same.
Crucial concept. Means different brands of the same drug deliver the same amount at roughly the same rate.
Okay, so the drug's absorbed. Now it needs to get distributed around the body. And it doesn't just spread out evenly.
Not at all. Distribution is very uneven. Depends on the drug itself, blood flow to different areas, how easily it gets out of capillaries, and how much it binds to stuff proteins in the blood, components in the tissues.
So it goes to high blood flow organs first. Liver, kidneys, brain.
That's the initial rush, yeah. Then slower distribution to muscle, skin, fat.
And binding to plasma proteins is a big deal. Albumin for acids, alpha-1 acid glycoprotein for bases.
A very big deal. It's like a reservoir in the blood. Only the unbound, free drug can actually leave the bloodstream and have an effect or get eliminated.
So if binding changes, the free concentration changes.
Exactly. If another drug competes for binding sites, or if protein levels change due to disease, it can increase the free fraction. This is most important for drugs that are highly bound, rapidly cleared, and have a narrow safety margin, like lidocaine. It can really throw off dosing if you're not careful. And just measuring total drug level can be misleading if binding changes.
And drugs bind in tissues too, not just blood.
Oh, yes. Accumulation in tissues creates another reservoir. Can make the drug last longer, but also cause local toxicity sometimes, like aminoglycoside antibiotics building up in the kidney or inner ear.
And some places are harder to reach, like the brain.
Definitely. The blood-brain barrier, those tight junctions between capillary cells, plus efflux pumps like PGP we mentioned, make it tough for many drugs to get in. Lipid solubility is key. Though inflammation can make the barrier leakier, the blood-CSF barrier is similar.
Bone and fat can store drugs too.
Yep. Tetracyclines bind to bone. Heavy metals, too. Fat is a big reservoir for very lipid-soluble drugs, especially in obesity. Because fat has low blood flow, the drug can leach out slowly over a long time.
And redistribution. The drug moving away from where it acts.
Right. Sometimes a drug's effect stops not because it's eliminated, but because it moves from, say, the brain to fat tissue. Thiopental anesthesia is the classic example. You wake up because the drug leaves the brain, not because it left the body.
Placental transfer, too, getting to the fetus.
Also important, similar factors apply: lipid solubility, binding. The placenta isn't a simple barrier. It has transporters, too, both efflux and influx. Generally, lipid-soluble drugs cross more easily. Important consideration during pregnancy.
Okay, drug distributed, hopefully worked. Now, metabolism, the body changing the drug.
Usually to make it more water-soluble, easier for the kidneys to get rid of. It's mostly about inactivation and preparing for excretion.
And how fast this happens follows different rules. First order versus zero order.
Most drugs follow first-order kinetics at normal doses. Means the rate of metabolism is proportional to how much drug is there. Double the dose, double the rate it's broken down, roughly.
But zero order is different.
Yeah, that's when the system is saturated. Think alcohol or high doses of phenytoin. The body can only process a fixed amount per hour no matter how much is there. The rate is constant.
And these metabolic enzymes, like CYPs in the liver, their activity can change.
Hugely important point. Yes, they can be induced, sped up, or inhibited, slowed down by other drugs, or even the drug itself. This is a major source of drug interactions.
So metabolism happens in phases, phase 1 and phase 2.
Generally, yes. Phase 1 often involves those CYP enzymes doing oxidation, reduction, or hydrolysis, usually making the drug a bit more reactive or water-soluble. Phase 2 is conjugation sticking on a bigger water-soluble group, like glucuronic acid. Makes it much easier to excrete.
Mostly liver work.
Liver's the main site, but gut wall, kidneys, lungs chip in too. And don't forget prodrugs.
Inactive drugs that get activated by metabolism.
Exactly, like an alloprol becoming an alaprolat. Can be used to improve absorption or target the drug better.
And our genes affect this. Pharmacogenomics.
Big time. Variations in genes for metabolic enzymes, especially CYPs, can make someone a fast or slow metabolizer of certain drugs. Huge implications for personalized medicine, predicting side effects or lack of effect.
Absolutely critical to understand all that.
It really is. Predicts interactions, helps tailor therapy.
Okay, final step. Excretion. Getting the drug and its metabolites out. Kidneys are king here.
For many drugs, yes, especially water-soluble ones. Kidneys handle it through 3 main processes. First, glomerular filtration, small unbound drug gets filtered out of the blood.
Like a sieve.
Pretty much. Then, active tubular secretion transporters in the tubules actively pump drugs from blood into the urine. Competitive process can be saturated.
Then finally, passive reabsorption. Back into the body.
Right. If the drug is still lipid-soluble and uncharged as it goes through the tubules, it can diffuse back into the bloodstream. And again, urine pH matters here, making urine alkaline traps weak acids, making it acidic traps weak bases, enhancing their excretion. We use this in poisoning cases.
And kidney function changes with age.
Yes. It's lower in newborns, declines in the elderly. Dosages often need adjusting in these groups.
Kidneys aren't the only exit route, though. Liver again, bile.
Liver excretes drugs into bile via transporters. Bile goes into the gut. From there, the drug can either be eliminated in feces or potentially reabsorbed back into the blood.
Enterohepatic recycling.
That's the one. Can make a drug hang around longer. Sometimes we give things like charcoal or resins to bind the drug in the gut and stop it being reabsorbed. And of course, any drug not absorbed orally ends up in the feces too.
Other routes. Sweat, saliva, breast milk.
Minor routes mostly. Sweat, saliva, tears, not much drug usually. Breast milk is important though, potential exposure for the baby. Basic drugs can get slightly concentrated there. Lungs are key for getting rid of anesthetic gases, and hair scare analysis is used in forensics.
So all this ADME stuff comes together in clinical pharmacokinetics, linking the drug concentration to the effect.
Exactly. It's about using these principles to design dosing regimens that work well and are safe. How much drug, how often, to get the desired effect without toxicity.
And those 4 key parameters help. Bioavailability, F, volume of distribution, V,
Clearance, CL, and half-life, T12. They quantify these ADME processes. Volume of distribution, remember, isn't a real physical volume. It's an apparent volume, tells you how widely the drug seems to spread out. Big V means lots in the tissues, not just blood.
like figuring out the size of a swimming pool by seeing how much a drop of dye spreads out.
That's a good analogy. Clearance is about efficiency, how quickly the body removes the drug, usually measured as volume of blood cleared per unit time. It's what determines the steady-state concentration you reach with continuous dosing.
Steady state being when drug in equals drug out.
Right, levels plateau. The formula is simple. Dosing rate, clearance times the target steady-state concentration, CSS. Clearance is additive kidney plus liver plus other routes. And obviously, if kidney or liver function is down, clearance drops.
And volume of distribution, V, reflects tissue binding.
Yes. A high V, like for digoxin, means most of the drug is outside the bloodstream, bound up in tissues. We sometimes use multi-compartment models because drugs don't instantly distribute everywhere. There's often a fast phase into well-perfused organs, then a slower phase into other tissues. V is the steady-state volume in those models.
And steady-state concentration, CSS, that's our target level.
Often, yes. It depends on the dose, the dosing interval, bioavailability, and importantly, clearance.
Half-life, T12 then, is just how fast the level drops by half.
Pretty much. It's related to both V and CL. K12 is proportional to VCL. It tells you how long the drug persists, and it dictates how long it takes to reach steady state, roughly 4 to 5 half-lives.
So changes in V or CL change the half-life.
Definitely. If clearance decreases, like in kidney failure, half-life gets longer. If V changes, that also affects it.
Bioavailability and absorption rate matter too, especially for pills.
Absolutely. Bioavailability, F, determines how much gets in overall. The rate of absorption affects how quickly you reach peak levels and how high that peak is, but not the average level at steady state if you're taking it regularly. Controlled release smooths out those peaks and troughs by slowing absorption.
What about when things get weird? Non-linear pharmacokinetics.
That happens when systems get saturated, like metabolism, as we said, zero order, or protein binding, or active transport. If elimination gets saturated, like phenytoin, small dose increases can cause unexpectedly huge jumps in concentration. Half-life isn't constant anymore. Gets tricky.
So putting it all together for dosing. Therapeutic window.
Right, the concentration range where the drug works but isn't toxic. Between the minimum effective concentration, MEC for benefit, and the MEC for toxicity, we design regimens to stay in that window.
Maintenance dose keeps you there.
Calculated using the target concentration, clearance, and bioavailability. Dosing interval choice depends on half-life and how much fluctuation you can tolerate. Narrow window drugs need careful interval selection.
And loading doses for a quick start.
Yep, an initial bigger dose to hit the target level faster. Calculated using target concentration and volume of distribution, loading dose, target CP VSF. Useful if you need rapid effect, like for arrhythmias, but risky high initial levels can be toxic, so often given slowly or in parts.
And therapeutic drug monitoring. Checking levels.
Crucial for some drugs. Measure the concentration, usually at steady state, often trough level just before next dose to see if you're in the target range. Helps personalize the dose by refining the estimate of the patient's actual clearance. Adjust dose based on measured versus desired level.
So wrapping this up, it's clear drugs take an incredibly complex journey. ADME, absorption, distribution, metabolism, elimination, that's all governed by membranes, drug properties, body processes.
It really is. And understanding these principles is just fundamental, foundational for using medicines effectively and safely.
Which leads to a final thought for you, the listener. Really consider how much we all vary in these processes.
Right. Your genetics, other illnesses you might have, your age, your sex. All these things can change how your body handles a drug. Sometimes dramatically.
It really highlights why personalized medicine is such a focus and why careful monitoring is still so important.
Absolutely. And it makes you wonder, doesn't it? What's next? How much better can we get at tailoring drugs, the delivery, the dose, specifically to each individual based on all these factors? It's a really exciting area to think about.